Hi, everybody, and welcome to the ACEP Now Roundtable on the emergency medicine workforce. I'd like to thank all of our roundtable members for joining me today. We'll hopefully have a nice conversation. We'll do some brief introductions. There's Dr. Jesse Pines, who's the National Director of Clinical Innovation at USACS and a professor of emergency medicine at Drexel. Viktoria Koskenoja, who is the chair-elect of the rural section of ACEP and practices in the Upper Peninsula of the state of Michigan. Jay Mullen, who's the chair of the Democratic Group practice section and is a practicing EM doc and CEO of BlueWater Health, which staffs ERs and urgent cares throughout New England. And Sudave Mendiratta is chair and chief of EM at UT Erlanger, also serves as the president of the Tennessee Chapter of ACEP. So released in August of 2021, so just hot off the presses, Dr. Carolyn Marco and others published the Emergency Medicine Workforce projections for 2030. And today we're going to dig a little bit into that paper a little bit, discuss the real impacts on emergency medicine over the next decade. And the first question that I have, in considering that this is a modeling study, they're making estimates and trying to figure out what the workforce is going to look like in about 10 years, is that a lot of assumptions go into making these projections. So, for instance, the continued growth of nurse practitioners and physician assistants, which could range anywhere from 2% to 8% based on the projections they made. The continued growth of residency graduates, the attrition of EM physicians, whether or not they are trained in emergency medicine or trained in another field and work in EM. And then the average physician productivity, which I thought was pretty interesting. They said we're supposed to see 2,300 patients a year. And then also, where are ER volumes going to be? They're estimating approximately 11-12% increase over the next several years. And one final thing is that I found interesting, I didn't know the numbers myself, but about 1 in 5 ER patients is going to be treated completely by a nurse practitioner or a physician assistant without ever seeing an emergency physician. So let's go around, first of all, and I want you guys to tell me, do you think any of these estimates are faulty or anything that we need to look at with a little bit more rigor before we dig into some of the implications of it? I'll start with Dr. Pines.
Sure. Thanks, Cedric. It's interesting. I think that we need to step back a little bit. Usually when workforce reports come out, they're largely ignored. And if you look at historically at AMC workforce reports over the last many years, and there's one every year, and typically the punchline is there's not enough primary care, and there's we may need some more surgical subspecialists, and this one garnered a lot of interest, and I think to answer your question, I think whether any of those estimates are valid or whether or not this will be valid in 2030, in my historically looking back, traditionally these reports end up being completely wrong, very wrong, or slightly wrong. So I think that that's the best information they had using 2018 data. The world has completely changed since then. There's a lot of new things that are occurring. This is a complex adaptive system. So, I think it's a huge issue, but I don't really put a lot of stock in the actual results of the workforce being anywhere near what will be truth.
Right, Dr. Koskenoja, any opening thoughts on your end?
Yeah, I think it's really interesting because just last year in summer 2020, there was a workforce study by Dr. Carlos Camargo, who does a lot of workforce issues in emergency medicine. And they were talking specifically in that about a shortage of rural emergency physicians. There's already a maldistribution problem. And even if there happens to be an oversupply of emergency medicine trained physicians, there may still be this persistent maldistribution where people are wanting to work in major urban areas, not so much coming to the rural areas. And so it's going to be interesting to see how this settles out over time. As to whether any of the assumptions are faulty, again, very hard to say. I think that, I'm not involved in any emergency medicine residency training, so I haven't seen, the people having a hard time finding a job yet or concerns like that. So I'd be very interested to hear what my more academic colleagues have to say about that aspect.
All right. Dr. Mendiratta, do you have any opening thoughts first looking at this paper?
Sure. If we look at the background assumptions, I think we can split hairs about the data, but in the end, I think we have some pretty consistent warning signs that the trajectory that we are currently on, not just with emergency medicine, but as healthcare as our nation, that there are some red flags going up. And I think having a cautious and intelligent conversation now before we reach a crisis level is imperative for our specialty.
All right. And last but not least on the introductory comments, Dr. Mullen.
Yeah, I think, what Jesse was saying is exactly right, which is that the study's going to be wrong in one way, shape, or form. We know that. But it's kind of like, I use it akin to a climate change, right? So there are studies that take tons of assumptions in there, and they're going to be wrong. But they generally give us a sense that, climate change is happening, it's going to be bad for us, and we've got to take some action. And I think that this study was kind of similar to that they gave a broad range of variables, but they ended up in the same rough place in almost every scenario. And it actually fits pretty well with what my group's been experiencing and friends of mine from across the country who run groups, which is there's actually way more CVs coming in for every position that we've been posting pre-COVID. And when I hear everyone in every part of the country saying that, it kind of gives me a sense that this study is partially right, at least.
All right, well, let's get into a little bit of it and some of the issues that come out from it. So number one of the things I took away from it, they're estimating that right now maybe about 67,000 total EM practitioners, of which emergency physicians make up 70%, physician assistants 15%, NPs 8%, and family medicine, internal medicine doctors combined maybe about 6%. The future of emergency medicine, what should it look like? Should it be all board certified EM physicians? What's the role of all these other different professionals in the mix? Let's start with Dr. Mullen.
Yeah, I think, if we're going to define the perfect world, we're going to want high value medicine, right? High quality and high value. And it's going to be really hard to justify a board certified emergency physician getting paid what we currently get paid to take care of the simple lacerations, the ankle sprains, the low acuity patients that come through the door. So I think we have to recognize that they are an important part of the team. The non-physician providers are actually helping to leverage the emergency physicians to see the higher acuity cases. And if we try for a world that's only where the EDs are only staffed by board certified emergency physicians, then we are going to need a lot of them, but we're not going to be able to afford them. And so we'd have to have a very different lifestyle.
And what about in the rural environment, Dr. Koskenoja? Where do you see?
Yeah, I would say my concern is sort of counter to that, in that I'm seeing a lot of rural emergency departments where there are no physicians. And there's not currently any standard of the size or volume of an emergency department where it requires a physician being present. And so I think there are physicians being replaced by non-physician practitioners in order to save payroll costs and purportedly to provide more value. But I know from personal experience that patients are being hurt in these scenarios when there's someone who is newly graduated from a non-physician training program and just has a couple years of training after college and just basically taking care of someone alone. And that's not a safe environment. And because we don't have any standards about when we need to have physicians present in emergency departments and what types of cases they should be managing, it's kind of like the wild, wild west out there. There are departments where there are no physicians. And I don't think anybody should be advocating that that's a good idea, to have no one accessible even by telemedicine if there are questions or concerns.
I think we'll get into that a little bit later on in more detail, because the ACEP board has some recommendations around that point. But let's start with Dr. Mendiratta. Shift the question a little bit. Right? We mentioned like 1 out of every 5 visits is going to be handled by a non-physician clinician. Does every ER patient need an ER doctor for every single case? And if that's not the case, then what kind of standards should we be setting in place?
Well, I think that an emergency physician should be the leader of a collaborative care team. And I think that depends on somewhat of locality. The 1 in 5 patients not being treated by a physician is that 1 in 5 patients or 20% of our patients that don't need an emergency physician. Those patients come to the emergency department with the belief of having an emergency. And we know that our own ACEP data from about a decade ago shows us that only 2% of all emergency department visits are non-emergent. So I think we have to have a physician lead for all visits, but is the 1 in 5, is that a commentary on our broader healthcare system, that we serve as a safety net for a large proportion of America's population? And how do we work collaboratively for solutions to deliver care for patients that otherwise don't have access to care?
All right, Dr. Pines, I saw you nodding along with this. Thoughts on that issue as well?
Yeah, I agree with what others have said. I think that the current and future of emergency medicine really lies in team-based care. And I think it's about having, ensuring that physician skills are used for the right cases. And I think rural areas are a current area where there's a really big issue now, where there are just not enough board-certified emergency physicians who really want to live and work in rural areas. And the result is when those patients come in critically ill, they may not see someone who's got the best training experience, because that, either the doc doesn't want to live there, or the hospital can't afford a board-certified physician, or other issues. So I think that, certainly teams are now in the future, but we really have to directly address the rural issue. I think that's not a 2030 issue, that's a today issue.
All right, well, let's go back to Dr. Koskenoja about that one then a little bit, because we keep hearing sort of the maldistribution. You brought that up, and I want to hit on that topic again, because right now we're talking 47,000 emergency physicians, projections for, there being that supply-demand mismatch by several thousand physicians over the next 10 years. And your concern was not necessarily a supply-demand mismatch nationally, but more so a mismatch, I would say, based on location, where we have geographic maldistribution. What would you do about that? How would you address that situation?
Yeah, actually, rural ACEP has a resolution related to that coming up this year. Most people who want to work in rural areas are people that are from rural areas. I know this from personal experience, and the research also bears out on that. And also, there are some studies showing that having exposure to rural practice as a medical student or as a resident increases the propensity to practice in an area like this. And so there are some innovative models that are coming up in areas like West Virginia and also in Vermont, where they're having sort of an academic and community or critical access hospital hub and spoke model, where physicians who practice at the main campus will also go out to these rural areas. That allows good learning opportunities also for medical students and residents. I mean, one of the main hurdles, honestly, is that to be considered an appropriate elective in a residency training program, there needs to be a board certified emergency medicine physician there in the ER when these people are learning in their ED sessions. And a lot of rural places don't have that. They have a family medicine doc or somebody that's not board certified. And so making sure that we have board certified emergency physicians going to these areas so that students and trainees and residents can get out and get those experiences is one of the big ways to do that. And just to piggyback off of that, recruitment of people from rural areas. I mean, we talk a lot about diversity in medicine, but we don't talk about diversity of where people come from or, their income levels of their families of people going into medicine, that kind of diversity. And so, I mean, everyone I know who practices in the rural area where I live is basically from this area. And so that's the reason they came back. And so having scholarships for people from these areas, having training programs associated with state universities to help promote students going into health professions from rural areas. That all helps, but it's a very slow process to, get these people through the training pipeline. So I wish there was a miracle cure that could fix this, but there's not.
All right, Dr. Mullen, do you have a miracle cure for rural emergency medicine?
Not a miracle cure, but I think everything that Viktoria was saying is right on. And I would add that this might be a little bit of the silver lining of the oversupply is I work in a couple of critical access hospitals that are very remote, very small. And when we started our contract there, they had one doctor and everyone else was per diems or travelers. And they couldn't get anyone to sign on. And it's not a surprise, really, because who wants to sign on to a dysfunctional team, right? That they know they're going to be left holding the bag. And what we found is over the years is once we actually stabilize the staffing, we find that some people really enjoy the challenge of rural medicine because it's much harder medicine than when I work in my inner city hospital where I have lots of specialists. So I think that there will be a net improvement from that perspective. I just want to add one other thing, echoing what Viktoria was saying. My home state is Maine, and we're seeing a lot of scope of practice issues where PAs can be independent practitioners, similar to what NPs can do. And that scares me a lot because we probably all know some NPPs who are phenomenal and could take care of anything. But they are a rarity, and the financially strapped rural hospitals that are having trouble staffing their emergency department, they may reach out and start having an independent PA or nurse practitioner work there, and that's just so wrong for the patients, but also so wrong for that practitioner because they're going to be faced with challenges they're not up to, and that can sometimes be career-ending.
I would like to add on to that as well and just say that even in my state, which requires supervision, there are, the supervision is nominal. It's a signing of some charts. So basically, even in the states where that's not legislated that they're independent, NPs and PAs are practicing completely independently, just having some chart review later. If something is missed in the exam, if something is missed in the workup, nobody's going to know until it's way too late. And this is a very concerning issue in rural areas. And one of my great concerns, because I live here and my family lives here and a lot of people I care about, is that it's going to become a two-tiered system where people say, oh, you know what, it's just a bunch of hicks out there. We'll save the doctors for the city because that's where everybody matters. And what about me and my family and all the people I care about here? We don't deserve a second tier of care just because we don't live in a major urban center. And I think that primary care and emergency medicine are the two areas where, we really should be advocating for excellence in care. Nobody expects to get a liver transplant when they live in a town of 2,000 people where they live, but you should be able to get good primary care and good emergency care anywhere in the country. That should be our goal, not having a two-tiered system.
All right, well, let's look a little bit into that even more. The ACEP board wrote an article in our April issue of ACEP Now discussing the workforce report, and they had several different bullets. I want to get into some of them, but since we're on the subject already of nurse practitioners and physician assistants, let's dig a little bit into this bullet point. They wrote, ensure appropriate use of nurse practitioners and physician assistants to protect the unique role of emergency physicians was one of the takeaways that they had from that. So let's start with Dr. Mendiratta on that and then go to Dr. Pines.
So I think that the appropriate use of APPs should not be determined by economic factors. It should be determined by the needs of our patients. We signed up for this to serve our patients, any patient, anytime, any place. And I think that we should examine ways to remove some of the economic incentives and then allow a physician-led team to create regional practice patterns. I think that there is a significant difference between what we deliver at our safety net hospitals and rural hospitals. But the thing that's in common between those two is a distressed payer mix. We have to be very cautious on how we approach scope of practice issues so we don't alienate our patients. But I think we should also understand the rationale for the development and proliferation of advanced practice providers, which is primarily economic.
Dr. Pines?
Yeah, thanks for that comment. I totally agree. So I'm going to agree and then disagree with one of your points. I agree that it should all be around patient care, and the reason that we do what we do every day is to provide the best patient care. There are models out there where APPs can do patient care safely in a supervised environment with standardization of training. And I think that's clear. And actually, I published some studies recently demonstrating that a if you have a system in place to train people, that you actually can do that safely. And we didn't see any safety signal or really large, deviation in practice when we looked across all of our sites. Secondly, so I totally agree with what you said there. Secondly, I think there's a little misunderstanding of the economics of APPs, advanced practice providers, and we actually looked at that across our sites, about 13 million visits, and actually did not find any economies of scale, which is basically means that a higher proportion of APPs at the day level was actually not associated with any sort of improvement in billing or any real sort of staffing efficiency that was observable across. This was a sliver of about 2 to 3% of the visits in the country across 5 years of data. So we did have, I think, a pretty big sample there to look at. So I just to clarify that, I'm not sure I agree with the economics of it. And then third is I think we need to continue to, try to find the best models for APPs, and the model that USACS uses, the standard training and all the things we do. Not every place has that, and not every APP has physician backup and the supervision that they need. So to agree with Viktoria, that's really what it's all about, is making sure that you're doing things where people have the support that they need to deliver the best patient care.
Could you expound just a little bit on the training model? Because you said that there was some additional training thrown in.
Yeah, so in our group, we do have a standardized programs for APPs where they get onboarding, local mentorship, chart reviews. We've got clinical management tools that are used across all of our sites, by doctors and APPs. And actually, interestingly, when it comes to the clinical management tools, at least looking at some chart reviews, doctors are a little more likely to deviate from them than some of our APPs in our chart reviews. And that the APPs will sort of follow the rule, and then doctors will look at the rule, will know the rule and see the rule, and then come up with a reason why they're going to deviate from the rule. But that's just sort of what we've seen in our chart reviews. Again, we haven't statistically looked at that.
Okay, well, thanks so much. Let's shift gears a little bit from APP training to physician training. There's a lot of commentary about residency programs. One bullet from the ACEP board in the article that they put up in ACEP Now was to stop the proliferation of emergency medicine residents and residency programs. We've seen large growth in that sector over time, and it was necessary growth, as this paper described. The profession started in the 70s with no training, and now we have several hundred residency programs. So what do you all think about the need for more residency programs, more residents coming out, especially considering this current year where residents have had a very difficult time finding jobs? Let's start with Dr. Mullen.
Yeah, in a perfect world, we would have the perfect number of residencies. And of course, we don't live in a perfect world. And it does bother me a lot to think of those medical students who are excited about emergency medicine. They compete for a spot, they get a spot, and then they come out. And if we have an oversupply and they can't find a job anywhere close to where they want to be, that is problematic. And I think that we used to control this because the government would help to subsidize the residencies. And now that that's not such a friction point anymore, I don't see how we actually control the number. And in some ways, it almost has to be, once there's an oversupply of emergency medicine trained people that can't get jobs, then the specialty loses its polish and loses its kind of lofty status, and then that's not a place we want to be. We want to be a place where the best minds, the brightest minds, the most energetic medical students are choosing to be in our profession.
Dr. Mendiratta, what are your thoughts on that?
Regarding residency training, I think we have an opportunity to increase the quality of our training. ACEP has been actively engaged in discussions, at least initially, with how do we define competency and some of the newer skills that we've developed over the past few years, such as point of care echocardiography, which really can make a huge difference in a patient's life. So I applaud our collaboration with organizations like CORD, that we can come to the ACGME with data that supports competency-based training, because we're here to deliver quality care to our patients. I think another aspect of the proliferation of residency programs is we have to revisit some of the somewhat antiquated rules set forth by CMS regarding hospital status and hospital funding of residency positions. There's a current term of a hospital that has not had residents yet, called a virgin hospital, is unfortunately in some markets preferentially selected as a residency training site due to the economic benefit of the sponsoring institution. I think we have to circle back and reevaluate what our patients need. The patients that live in rural areas, that live in economically depressed areas, have the right to academic medical centers, just like patients that live in a preferential payer mix. So I think we have to detach the economic incentive from in some markets for-profit hospitals and non-for-profit hospitals to start residency programs just for the sheer fact that it's cheap labor, that it's underwritten by the federal government. I think the solution to this is ongoing conversation with CMS on how we can reform the overall GME funding system to better reflect the needs of the American healthcare population.
And Dr. Pines, any ideas?
Yeah, just a couple of follow-ups, and I agree largely with what you said. I think that I do agree that we do need better competency-based assessment out there. What I disagree with is that we need better competency-based assessment in order to limit the supply of emergency physicians, which was, so I think tying that to the workforce report is not really the spot for that. I think if we need 4 years to learn how to be an emergency physician, or 3 years, or however, 5 years, however long it takes, in Canada I think it's 5 years. That's the right time. Secondly, in terms of the jobs report, the workforce report, and the current job market, I think that there was sort of a conflation of the two this year, where the workforce report came out at the same time that graduating physicians were having trouble getting jobs because of the COVID and the basically the temporary reduction in visits that we saw because of the big black swan that hit the world and continues. So I think sort of separating that is important. And then third, in terms of controlling the supply of residency programs, I agree there are some sort of perverse incentives in terms of starting residency programs, but I think we also have to realize that this is the job. Any workforce is basically a complex adaptive system, and as if there are no jobs in emergency medicine, people are not going to go into emergency medicine. I mean, that's the issue. If there's medical students are going to see the writing on the wall, and they're going to say, look, there's no jobs over here. I mean, I remember I was training right around the time that LASIK came out for ophthalmology, and there was a huge flood. I mean, everyone saw this massively profitable procedure that ophthalmologists were going to do, and ophthalmology residencies became much more competitive after that. I mean, medical students, I think, are going to see the writing on the wall, and you're going to see an adaptation based on job choice, going into these programs as opposed to necessarily starting new ones.
Dr. Koskenoja, with what you see in sort of the rural environment, do you think there'll be any impact one way or the other of more or less or stable residency programs?
Yeah, I mean, it's really hard to say because we're always sort of lagging behind everything else. I think that the rural sites will start to be able to attract board certified emergency medicine physicians if there are no other jobs for them. And so there may be this sort of lag effect where those will be the last spots filled And then after that point, emergency medicine may become less appealing. But I do agree with what Dr. Mendiratta was saying, was that we want bright, hardworking people to be attracted to our field. And so it's sad to say that it may have to go that direction where people just can't find employment, and then we no longer have the best and the brightest coming to emergency medicine.
So in order to avoid that happening, one of the things that the ACEP board had talked about was supporting practicing physicians to encourage rewarding practice environments in all localities, specifically with an emphasis on rural locales. What do you think needs to be done to make rural medicine more intriguing, especially for people that aren't from rural communities to begin with?
Yeah, that's hard because there's always this, thing that happens where people will come to a rural area when they're not from a rural area, and they'll last for a couple years, but then they'll have kids and want to go back to be near their family, or their spouse hates it because they don't have amenities that they're used to. So there are many reasons why it's hard to attract and especially retain people who aren't from rural areas. But I would say that loan forgiveness for practicing in a rural area is huge, and offering competitive salaries. So the funding structure changing would be helpful. And then, like I said, recruitment and exposure to rural emergency medicine. I mean, like Dr. Mullins was saying, rural emergency medicine can be very challenging, which is fun and interesting. And you don't have to jump through all the hoops and call 5 specialists because they're not there and you're it. And so I've gotten to do a lot of really fun, interesting stuff since I started my job here in a rural area that I just wasn't exposed to in residency. Doing my first pericardiocentesis alone 2 months after I graduated. That was really interesting. And you get to use the full scope of your skill set. And so I think it can be a wonderful, rewarding career as long as it meets all the other criteria in people's lives. And that's the hard part. It's not so much the medicine that's not appealing to in my mind, it's the locale. And so that's why I think it's so important to increase recruitment from rural areas to medical schools.
So other than maybe that pipeline issue, like you said, getting people from rural areas into medical school, so with the hopes of them going back, because we see that trend. Dr. Mullen, do you have other ideas of what you might try to do to make rural medicine more interesting for emergency physicians?
Yeah, and so much of it is just being exposed to it. During COVID, a number of our doctors went down to New York to help out there, and they ended up befriending some of the attendings in some of the residencies there, and they ended up hosting a resident up into one of these rural critical access hospitals in Maine. And that resident had such a great experience that he then told his residency director, and now we have a regular rotation of emergency medicine residents coming through because they love the medicine. Because like you were saying, Viktoria, it's so challenging, but it's also so rewarding. I mean, where else do you have people coming in from home to help out because you've got 2 really sick people in the department, and everyone like pitching in. So that part is fantastic. The other part too is as the practice gets stabilized, then there's more enjoyment because when it's a understaffed emergency department, by that I mean regular people versus itinerant physicians, it just is so challenging because you can't standardize care, you can't get the buy-in that you need. But once you start to build the team, they actually really like to come back. We routinely are turning people away. And the only other thing I would say is a challenge that can be really hard to get past is not every physician wants to move their family to a rural area. So sometimes we find that a mix of shifts in the suburban area and shifts in the rural area actually works out really well for them. And I remember one of them telling me when we were interviewing him, he's like, yeah, I want that urban setting just so I don't let my skills rust. And about 6 months after he started working in the rural area, he's like, oh my God, I had to polish those skills again, not for the urban setting, but for the rural setting. And he loved it.
Very good. Thank you very much. So Dr. Mendiratta, do you have any thoughts on that particular issue as well? And one of the things that I was just thinking about was, should we have a requirement for every EM residency program to have a rural rotation?
I think the rural emergency medicine, as practicing in a critical access hospital in a city of about 2,000 people, is truly a magical experience. And it is the practice that I look forward to the most in my career. Regarding how do we incentivize physicians to go to rural areas, I think some of the thoughts about splitting shifts between suburban and rural areas is a great incentive. I think we also have to realize that all rural hospitals outside of emergency medicine are also endangered. What we are facing within emergency medicine, the same as with OBGYN, surgery, psychiatry, that we have to look at how we deliver healthcare to rural America as a system, because it's not just us, it's all of healthcare that creates that inequality from zip code to zip code.
And getting into that, there's so many different things that we need to do to maybe expand our scope of practice, right? Whether it is telemedicine, freestanding emergency medicine, how we interplay with things like retail clinics and all that. Is there something that, of those or some other novel way to deliver emergency care that we need to consider for ourselves as a profession so that we don't cede territory to other aspects of the healthcare system? Let's start with Dr. Pines on this one.
Sure. I would 100% agree with that the role of emergency medicine is not necessarily to be in a brick and mortar emergency department 24/7. And I think that is definitely not the future. That's part of our future, but that's certainly not all of our future. I think that there's going to be tremendous growth in other areas that actually wasn't really captured in the workforce report, like telemedicine, like innovative models that could actually impact rural emergency departments very well. I think Viktoria mentioned some of those having, a hub and spoke model where you would share information and be able to see patients remotely and have a centralized way to deliver care. And I know that that's taken off in a number of states. Mississippi has had a program for 10 years. I think Minnesota has a similar hub and spoke program with the Mayo Clinic. I think those sorts of programs are really the future. And I think the role of emergency medicine is not just to think about our skill set in our brick and mortar hospital, but to think about what can we do for patients outside the hospital. And there's tremendous value there. I mean, if you look at what the Kaiser emergency physicians do in an integrated healthcare system where there's a fixed amount of money, they spend on average about 30% of their time outside of the emergency department doing other things and coordinating care. So I think that's really our future and where we can be most valuable.
Dr. Koskenoja, you had mentioned telemedicine earlier on. Number one, do you have access to that in your department where you are, or is that something that's more of an aspirational thing to try to deliver some of that specialty care?
I have a mixed experience with telemedicine. So we use telestroke to have a neurologist available. And then we also briefly had a burn specialist that we were able to, do video chats with so they could actually physically see the burn and see what we were talking about. That was great. I will say that, there can be a lot of technological glitches with that, and that can be very frustrating. If you're, about to push TPA and you want the neurologist to weigh in and the camera's not working and the machine wasn't plugged in, there are all these technological problems, but, in the real time that can create a lot of stress. I will say the other thing I worry about is physician satisfaction with that. I have done some telemedicine myself, and sitting in front of a computer screen isn't something I enjoy doing all day. And so I worry that if we're saying, okay, there aren't going to be enough regular emergency jobs, so you can just sit in front of a screen all day. I mean, we didn't become radiologists for a reason. It's not what most of us want to do. I want to touch people and talk to them and smell all the stuff that you do to be a good emergency physician. And so I think personally, my job satisfaction would plummet if I was doing telemedicine. But like I said, sort of a mixed review of it is that I feel like in these super rural or like extreme frontier hospitals where they're seeing less than 0.5 patients an hour, they're not really seeing many patients at all, having telemedicine access to a board certified emergency specialist seems like a great way to improve quality of care. But as long as we can keep people interested in that job.
I agree with everything you said, except for maybe the smells part. I don't know if all of us want the smells of emergency medicine, but
yeah. Maybe we can just keep the feet out of it.
Yeah.
All righty. well, we're closing in on the end here. So if you guys have any questions that you want to ask other panelists, start thinking about that so that we can address them. But one of the things that the ACEP board wanted to consider was, is this now the time for emergency medicine to consider accrediting emergency departments? So we have a say in what defines an emergency department and how it should be staffed, how it should be supplied, et cetera. Let's start with Dr. Mullen on this one.
Yeah, that's a tough one because on the one hand, it seems like a perfect role for ACEP because what we want to do is make sure that there's a physician-led team in the emergency department, and that physician is a board-certified, well-trained emergency physician. When I think about applying that to my own group, across 7 different sites, I think, well, I've got some fantastic physicians that didn't go through emergency medicine. I've got some fantastic PAs. So it's going to be, the devil will be in the details, but overall, I think that this is a great area for ACEP to look into to help give some guidance to both patients and to, the administrators at hospitals to help them put into perspective what they're planning to do. We have 2 emergency departments in Maine that are only staffed by PAs. And I think sometimes the administration may not know that that's not the norm. And something like certification through ACEP could be really helpful.
Dr. Mendiratta?
I think we have to be cautious on how we approach certification. I do think it's a good idea to establish best practices and do everything we can as a college to ensure high-level quality care for every patient that enters every emergency department in the country. I think we have to be mindful that excessive regulations and certifications can be a negative impact on physician wellness. And also we have to consider how this will be used in the reimbursement realm of certified versus non-certified emergency departments. I think it's a great conversation to have and look forward to further engagement on how our college can be leaders in this. But I agree with the previous commenter. The devil will be in the details on how we actually accomplish some of these goals.
Dr. Koskenoja, your thoughts?
Yeah, I completely agree that it's a complicated question. I would love to see departments that are, basically replacing the physician role with potentially a new grad non-physician practitioner just to save money. I would like there to be some rule against that because I do see that is hurting people. And right now, hospitals can basically do whatever they want and still call themselves an emergency department. And so I think that's hurting people in real life. And so it would be nice to have some regulations. But I agree, having more regulations means more paperwork, more physician burnout, potentially rules that end up causing more problems than they solve. And so I think that it is a great discussion to be having.
And lastly, Dr. Pines on that one.
Yeah, I think that we've got to be, I agree with everything everyone else said. I think we've got to be careful about trying to think through what's the problem we're trying to fix with this. Emergency departments already are accredited by another group called Joint Commission, and I think if the issue is we want to have more standardization, having another accreditation to go through would have positives in the sense that maybe ACEP and emergency medicine would have more control over standards in emergency medicine. And I think that would be a benefit. It would be a tax on hospitals to ACEP, essentially. That's, I think, the other unintended consequence there, or maybe intended consequence. And then for unintended consequences, I just from what Viktoria said, I agree that it could really disadvantage rural sites, especially if they tie, let's say the MIPS measurement or some other measurement of reimbursement to the resources in the emergency department. That's gonna disadvantage already the places that are already vulnerable. And I think the major issue that we haven't discussed yet here is the economics of rural hospitals, which is the basis for a lot of the issues beyond with the workforce. And I think having rural hospitals that maybe don't have the resources or funding to actually to to be up to the same standards, not because they can't recruit and for all those reasons, to give them less money or have penalize them for that, I think would be really not where we want to go.
All right. Well, thank you all so much. You've given me a lot to think about, and I think when other people have a chance to view this, we'll be giving ACEP members a lot to think about as well. One of the things that the ACEP board mentioned in their article back in April was expanding the reach of EMs to ensure that nobody gets left behind. And sort of in that vein, is there anything that you think that I've left out asking, a final thought that you guys might want to give the listeners? Let's start with Dr. Pines.
No, I think that in general, there are a lot of reasons to be really bullish about emergency medicine as a specialty and as, I guess, a function in medical care. I think that the way that innovation is shaking out, during the pandemic and post-pandemic, there will be increased roles for emergency physicians to participate in a lot of these new innovative models, and also I think to lead them. And I think that we really do see a lot of emergency physician leaders that really defining the next generation. So I'm very, I'm not sure which way the workforce, we're going to look back at it in 9 years and say that was interesting and that was wrong. I'm not sure if that's going to happen. That would be my guess. But I'm very bullish about the specialty, and I think that we really have an opportunity to communicate with medical students and still attract the best people.
Dr. Mullen, any final thoughts?
Yeah, I think, an area that we didn't touch on too much has to do with telemedicine and nursing homes. I think about patients who, struggle with dementia, they're in a nursing home and they need some level of care, and how disruptive it can be for them to end up in an emergency department, sometimes in a hallway bed with, all the craziness that happens in our emergency departments. And then oftentimes it takes them days to, get back to their baseline once they get home. And it seems like this could be an opportunity for emergency physicians to help bring the care to the bedside, at least in a virtual way, to keep the patients where they're going to be the healthiest and the most stable, and to, at the same time, to help that delivery system, which faces some pretty significant challenges.
All right, Dr. Mendiratta?
I have never been more proud to be an emergency physician than the past 18 months in this country. It has been an absolute pleasure to serve our patients in our communities. And we learned during the pandemic that this can be a catalyst for progressive change. The innovation that's been mentioned by my colleagues, innovations in telemedicine, but also being there to serve our patients, because we're the only place open 24/7, 365, not just in our bricks and mortar locations, but doing outreach, doing telemedicine, serving our patients that have behavioral health and mental health emergencies, and even becoming vaccination sites for our most vulnerable members of our society. I am optimistic that emergency medicine will continue to grow and flourish because America needs us, our patients need us, and we are here to serve them.
And Dr. Koskenoja?
Yeah, I think the one other thing that we didn't touch on too much was that I think burnout is very real in our specialty, especially in this time during the wave of the Delta variant and, some high profile physician suicides. And so I think something we need to be talking about when we're talking about workforce issues are job satisfaction. I think there's a great feeling of powerlessness amongst many physicians right now. And when we look at workforce issues and the potential of job loss amongst physicians, that's very unsettling to trainees. And so I think we need to be talking about what jobs people actually want, how we want the specialty to look. If people don't want to be doing telemedicine, I don't think we should be trying to force it down people's throats as their only career option in the future if they want to practice emergency medicine. We need to be protecting the real job that we all like, which is taking care of patients in front of us. And so I just hope that we can consider job satisfaction of emergency physicians as a major important issue going forward.
Well, thank you all for joining me. You're making my job easy here and a lot more fun to be able to sit and talk to some folks about this as opposed to just reading a paper myself. And if there are any of you that are watching this that are interested in submitting your ideas to the Workforce Task Force, please submit them. The website is www.acep.org/workforce. And I'd recommend that you go there and send your information to the people that are on the task force looking into all these issues over the coming year or so. Thank you all very much for joining me.
Thank you.
Thank you.
Thank you.